Okay, so the last thing we're going to do here is to actually use what we've been talking about over the last 3 short lectures to give you guys some examples of how you might put Bayesian approaches into practice when you see patients, when you try to make a diagnosis, when you try to decide on a treatment, when you assess how good a test is or not. So this is designed to give you guys a little bit of practice, and then we may give you some exercises to do as part of the homework to practice this more. So let's go ahead and get started. All right, let's get into it. So we're going to apply Bayes' theorem and likelihood ratios as a part of Bayes' theorem to clinical situations and see if that helps you guys understand why we're spending so much time talking about this stuff. All right, so let's go back to this case I mentioned in the very first lecture. Justin's a 13-year-old. He has sore throat, fever, swollen glands, and this has been going on for 2 days. On examination, you notice he's got exudate on his tonsils. They're red and inflamed, and he has pus pockets on them, and tender anterior cervical nodes, but no posterior cervical adenopathy. What is his probability of having strep throat? Is it high? Is it low? How do you know, right? And how good is the testing in terms of helping us understand? What would you do for this patient? Think for a second, what would you do for them? There are lots of possibilities. You could just treat him with an antibiotic, and sadly I think that's what happens in most of the world when someone comes in with this type of presentation. Without a lot of thought about it, they're just, oh, you have sore throat? Here's some antibiotic. I know in Jordan that works that way. You think you have a sore throat, therefore you go to the pharmacy and just buy an antibiotic without even seeing a doctor, right? So we want to think about it a little bit more carefully than that. So you could just treat it. Number 2 is you could do a test to help you decide whether to treat or not. And the third option would be we don't treat it and we don't test. It's so unlikely that the patient has the diagnosis that it's not worth wasting time and money on testing or on treatment. That the treatment may have more chance of harming them than helping them. Okay, which could be true of antibiotics with antibiotic resistance or side effects from the antibiotics if the patient has a viral infection instead of a bacterial infection. All right, so this is on the right, the main point of this slide, what I want to talk about, the Center criteria, or the modified Center criteria developed by this guy McIsaac and his colleagues. It's a scoring system to help us figure out, does the patient need testing? Does the patient need testing and then treatment if the test is positive? Does the patient need treatment without the testing because we're so certain that the patient has the disease? Or does the patient need no treatment and no further testing because they are very unlikely to have the disease? Okay, so the Center criteria gives you a point for each of these items. Do you have fever? Right, our patient did, so he gets a point. Do you have tonsillar exudate? If you do, you get a point. Other throat findings can stand in for this, like it's just super red in the back of the throat, or you have petechiae on the palate, the soft palate. But in general, the strict criteria are tonsillar exudate gets you a point, fever gets you a point, not having a cough gets you a point. If you have a sore throat and you're coughing like crazy, you're less likely to have streptococcal pharyngitis, okay? So without a cough, you get a point. If you have a cough, you don't get that point. You get 0 for that. And then the anterior cervical nodes gets you a point, okay? So you could have 4 points here, as it appears that our example did. Justin over here, it doesn't mention cough, so let's assume he doesn't have it. Therefore, he's getting 4 points on the Center scale. Now, he was also 13 years old, as we said. That matters. Why? Because strep throat is much more common in young people than it is in adults, right? You're looking at maybe 25-30% of the population with streptococcal pharyngitis in a case of sore throat. Amongst young people, children, and you're looking at adults where it's more like 5%, 5 or 10% at most that adults are going to have streptococcal pharyngitis. So this McIsaac, the modified Center criteria, so this part at the top is the Center criteria, the first 4 items. At the bottom, there's a modifier for age because the disease is more prevalent when you're between 3 and 14 years of age. It's neutral, in other words, it's much less prevalent when you're 15 to 44, but it doesn't lose you points, just doesn't get you extra points for consideration. And if you're more than 44 years of age, you're very unlikely to have strep pharyngitis, so you lose a point out of your center criteria. Okay? One thing to notice, so what does this mean? This has been studied extensively, and we'll tie it to Bayes' theorem in a bit. But when you have all 4 variables positive, you only have about a 40 to 60% positive predictive value for a throat culture. Okay, so you think they have strep throats, you do a culture in the sense that you get a culture back that's positive. If you have all 4 of those variables, the predictive value is only 40 to 60%. In other words, it's close to 50-50. In other words, it's not that predictive of actually having a positive culture. Isn't very predictive given all 4 things are positive, whereas a negative predictive value from the absence of all 4 variables is very high. If they don't have any of these, they do not have strep throat. You can be 80% certain they don't have strep throat if they don't have any of these characteristics. Right? They're highly unlikely to have it. So that's an example. We get a history, we examine the patient, we're looking at their throat, we're feeling their lymph nodes, we're taking a history of do they have fever or not, we're measuring their temperature, we're asking them have they been coughing, have they not. Tied to that, of course, is the history of runny nose, which isn't part of these criteria, but does reduce your likelihood of having strep throat if you're not under 3 years of age. So anyway, and just to mention, if you see a child under 3 years of age, 1, most of them aren't telling you they have a sore throat, and 2, almost none of them have streptococcal pharyngitis. Just as a pediatrician, I feel compelled to say that because you see a lot of kids treated for strep throat when they're 2 or 2.5, and that just is not really very likely at all. Okay, so what are the likelihood ratios? So this, again, I went back and looked this up on the NNT.com. Yeah, that is where I found this. Had to make sure. This is giving them credit for this. But what are the likelihood ratios? What is in other words, the increased probability of them having the disease with a positive test? So on the center criteria, if they get 4 points, it has a pretty good positive likelihood ratio. It will generate a significant shift in my confidence that they have the disease. If they've got 4 points on center criteria, even if they have a moderate probability of the disease, suddenly I'm feeling like they are much more likely to have that disease. We'll look at it on a graph in a second. 3 points, again, not a big shift, a moderate shift in diagnosis, a moderate to small shift in the diagnosis, but nonetheless, in an appropriate population with an intermediate probability of the disease, it could generate an important shift in how I think about a positive test. I am still increasing the likelihood that a positive test means they actually have the disease. Versus if you only have 2 points of the center criteria, you have a much lower likelihood ratio. In other words, you're not thinking a positive test means much. In fact, it means less. It lessens your diagnostic probabilities there. If you have 1 point, this gives you the 0.3 likelihood ratio, 0 points, the 0.16. And again, we're saying if they have 0 points, they don't have it, right? Okay, so you can see how powerful it is, that center criteria, because we've gone back and checked, and yes, it has a very high likelihood ratio for all 4 points being positive. Okay? 3, not as much, but still in an intermediate probability population like a child between 3 and 14 years of age, it could mean they're a lot more likely to have the disease. So these people, you may do further testing before you treat. These people, it makes the most sense just to treat if they're in the right age group, okay? And you guys you may have an intuitive understanding of this from microbiology, but I think this really helps you think diagnostically about it, and it gives you a way of thinking you can apply to other conditions where you might not know as much. when you start out. I picked a common one because I want you guys to have some intuitive understanding of this to help you grasp what's going on with Bayes' theorem and likelihood ratios. So let's look at that nomogram again. Again, am I going back and calculating the likelihood ratio? No, I looked it up on the NNT.com. Am I going back and calculating Bayes' theorem, the formula that makes up Bayes' theorem? No, I'm going to use this nomogram to help me decide whether my patient has the disease or not. So he's 13, he's in that 3 to 14 year age group, right? So we're going to assume, oh, interesting. No, actually, I did this differently. Okay, so this is for an adult patient. Okay, we're going to shift from Justin, or maybe let's just pretend Justin ages a few years and he comes back to the doctor with the same symptoms, all right? So I think Justin has about a 5% chance of having the diagnosis of strep throat. So he's an adult. He has a 5% chance of having it. But there's a high positive likelihood ratio for all 4 points present. So he comes back, he's presented exactly the same way. He gets 4 points on the center criteria. He gets 0 for his age, but he gets 4 points for his clinical presentation and examination, right? So you can see we start with the pretest probability of 5% in the population he's living in, his age group. And with that positive likelihood ratio of 6.1, we can see that his probability of having the disease got boosted to 20%. Okay, now, again, that's not very high, but he had a low pretest probability, right? So even having all 4 criteria, when you're in the wrong age group, your probability of having the disease isn't that high, okay? Conversely, oops, going the wrong way here. You can see that if he has only 3 of the 4 characteristics with that likelihood ratio of just above 2, his post-test probability over here is down to 10%. Again, he's only 10% likely to have streptococcal pharyngitis, strep throat. So you can see how important having those points on the center criteria are, and how having a really low pretest probability means that no matter what test you do, it's not that valuable. So maybe skip the test in low prevalence people, right? And that's what we do in general in medicine. This is why we do it. This helps you understand why we do it that way. Let's look at it from a different standpoint. Let's go back to Justin when he was a 13-year-old. Say he's got between a 25 and 30% chance of having the disease at baseline, okay? He gets 4 points on the center criteria. No, I'm sorry, in this case we're saying he got 3 points on the center criteria. His likelihood ratio is just above 2, 2.1. He goes to about a 50% chance of having the disease. That's where adding more testing, which again, Bayes' theorem applies. We can take this now 50% chance of him having the disease, add another test with a decent likelihood ratio, and be more certain he has the disease. What would that test be? I don't know, maybe a rapid streptococcal antigen test, right? Suddenly, knowing that he's now 50% likely to have the disease will change the performance of that test for us. He's no longer low prevalence or low intermediate. He's now, got a 50% chance. He's just as likely to have the diagnosis as not. So another test might help us boost our certainty even further. That's why with 3 points on the center criteria, you could opt either for just treating, which it depends on whether your priority is making sure we don't develop antibiotic resistance. So somebody like the Infectious Diseases Society of America says, no, don't just treat somebody with 3 points on the center criteria. Go ahead and do a rapid strep and maybe even a throat culture of that patient, because we want to boost our diagnostic certainty further, because we don't want to develop antibiotic resistance. We already have huge problems with that. We want to reserve antibiotics for the people who truly have a bacterial infection, versus the American American Academy of Physicians, the internal medicine doctors in America say, no, you actually should just treat that patient. They're 50% likely to have it. Just treat them. Treat them. Their likelihood of having a bacterial infection is high enough that it's worth giving the antibiotic and not wasting money on testing, because in truth, the likelihood ratio for a throat culture is not that great. The predictive value is not that great, like we just saw on the previous slide. So let's just not bother with that. Let's just treat. And also, strep throat isn't the only bacterial infection that causes sore throat. So maybe I get lucky and knock out a group B or a group G streptococcal pharyngitis instead of a group A pharyngitis. So in other words, I'm making people better. People are losing less time out of school and out of work. So it makes sense just to treat them and not waste time with more testing. Okay? This is why this stuff matters. You still have to interpret the data. This doesn't solve problems for you, but it does give you a much more confident look at what's my likelihood of this diagnosis being right. Okay, so you take something with a low intermediate probability, 25%, let's say, you apply a test that's not great, you get 3 points on the center criteria, you still have now a 50% chance of having the disease, and more testing might benefit you to become more certain. If you have 4 points from the center criteria, then you're 70% likely to have the disease if you have 4 of the criteria in this age group, right? So then you're just going to treat them. You already thought, this sounds like it. The central criteria say this is probably what he has. And in truth, how do I know the central criteria are helping me? Well, I plop it onto this nomogram. He has a 25% chance of having the disease pre-test. The test has a likelihood ratio of 6, above 6, 6.3. Therefore, I draw this line from the pretest probability through my likelihood ratio, my positive likelihood ratio, and it shows that my post-test probability is 70% that he has the disease. I'm just going to treat him with antibiotics, okay, and have a pretty decent certainty that he actually has the diagnosis, that the antibiotic's going to help him. And just to say, briefly, I hope you guys know that the antibiotics do prevent complications from streptococcal pharyngitis, but in truth, most people recover from streptococcal pharyngitis uneventfully. So it isn't super important to treat people. It's not really a huge deal if we miss some diagnoses, but it is true that we don't want to miss lots and lots of diagnoses, because there's a 1 in 1,000 chance of somebody with streptococcal pharyngitis developing a complication like rheumatic fever, which can kill you, which can have lifelong consequences if it doesn't kill you. So, you don't want to miss very many of these. We can afford to miss a few, but we do want to have pretty high diagnostic certainty to not develop antibiotic resistance by treating too many people, or by not causing a lot more rheumatic fever because we treat too few people. That's where all this really matters. It really comes into play and really helps you make decisions for patients. Okay, I hope that's clear. I hope it's clear how that could be helpful. We'll go through one more example before we finish, but I'm hoping that now that we've taken some time and gone through what are we talking about, how do we understand how Bayes' theorem is put together and how it works, what basically is a likelihood ratio and how does it work. I hope now you guys have a good understanding of how we use it now that we've gone through one example, and we'll do one more to try to consolidate things further. Just a review of what happens in Bayesian analysis. This isn't really about diagnoses and treatments. It's more about a health technology assessment. In other words, deciding how much the health technology we might want to introduce, that could be an antibiotic, it could be a diagnostic test, helps us take care of people. So first, we formulate the problem and decide what outcomes are important to making a policy recommendation in the case of health technology assessment, or making a diagnosis and treating them when it comes to a specific patient with a medical problem, okay? You want to understand, like, well, how bad is it when we game out the various scenarios, okay? Next, we want to specify our beliefs about what the situation is. In patients, it's going to be what's their pretest probability of having the disease based on the prevalence in their community, their population. Okay? And yeah, so once we have the problem set up, we want to think about, well, what's the pretest probability, the prior probability? We want to estimate the probability of the observed data given the prior distribution on the outcomes, right? This is where likelihood comes into play. Again, we're going back to the numerator of Bayes' theorem. The likelihood of the positive test, in our case we just discussed, matters a lot. It impacts our diagnostic certainty, our P, our probability of A given B, a lot. Because in the numerator, it has a big impact on the final answer. Then we're going to apply, once we understand all the pieces of Bayes' theorem, we're going to apply it, right? To estimate the probability of the outcome, to get that posterior probability, okay? Posterior probability comes from applying the equation, the analysis, based on defining all the data. And then lastly, we're thinking about, well, what about loss? Right? What about loss? This is the risk, the Bayes risk. What are the chances, given the posterior probability, what's the risk of making a wrong recommendation? It's like adding another layer, I guess, it's good to say, onto Bayes' theorem. You can use Bayesian analysis to, in series, I guess I want to say. You can apply it with a test, improve your certainty a little bit. You can apply another test and improve your certainty more. You can look at what's the problem. If I'm wrong, how bad is it? You can use Bayes to help you decide that kind of thing too. But again, just another look of how you can use Bayes' theorem, another talk through what we're doing when we apply Bayesian reasoning. And again, I'm hoping all of this is making things more clear. One more example to try to finish up and help you guys understand the power of Bayesian reasoning, how important it is to consider when we're looking at diagnosis specifically for our purposes. Again, it can apply not just in medicine, in all sorts of fields, but it has a particularly obvious application in medicine when it comes to diagnoses and testing, okay? So let's just say you have this awesome test to detect cancer. It's 99% reliable to detect cancer, right? Really good. In other words, 99 out of 100 people who have cancer will test positive. Okay, they've got cancer, so it has a high sensitivity, 99 out of 100, 99% sensitivity, 99% specificity. 99 out of 100 people who are healthy will test negative, okay? So a really good test. This shows you that a really, really good test still depends on how you use it. Okay, so for this case, let's say that we have a 1% chance of our patient having cancer in this population. A pretest probability, a prior probability of 0.01 or 1%. That's our pretest probability, okay? Yeah, this is exactly why I don't write on these things. My writing's terrible. So let's apply Bayes' theorem. Let's apply Bayesian reasoning here. So we have our test performance up here, 99% reliable, right? That's our, think of it as our positive likelihood ratio in a way. We didn't actually calculate the likelihood ratio, but just think of it like that for now. Okay, this is the likelihood function of the equation. 0.01 or 1% of people have it, the pretest probability in the population. So if you multiply these two things together, what do you get? You get 0.0099, right? I guess I should. So 0.0099, okay? That's what you're getting for the numerator. The denominator is basically positive testing we're looking at. Positive testing, all the positive tests. Well, we have to consider some of those positive tests are false positives, right? Okay? Some of them are going to be true positives, but also some of them are false positives. We want to calculate out of all the positives, how likely is our patient to have the diagnosis of cancer, okay, out of all the positive tests for cancer. So the false positive probability is that 0.01 times 0.99, okay? And our true positive probability is 0.01 times 0.99, okay? So in other words, the people who don't have the disease, 99% of the time will test negative. This is a great test, remember. Okay, but there's still that 1% of the 0.099 who will be a false positive. Okay. But then you have all the other positives. But again, here's the problem. Only 1% of the population has the disease. Okay? So even though it's 99% reliable, only 1% have it. Okay? So down here, what you get are 0.0198. You'll notice that the denominator is 0.099. This is going to come out to 0.0099. And this is 0.0099. So in other words, this is double. The numerator is half of the denominator. In other words, the probability of A given B, probability of having cancer given a positive test for cancer is 50%. It means that, okay, I give them this awesome test and they get a positive result. Because of the low prevalence of the test, of the disease, in the population, primarily, it's only a 50% chance I have cancer. So you tell a patient, we're going to screen you for cancer, even though it's 99% likely you don't have cancer, but we're going to use this as a screening test just to make sure, cancer is bad. We want to make sure you don't get cancer. If you have it, we find it early and we treat it. So we're going to give you this test, even though there's a 99% chance you don't have cancer and the test is positive. And you call the patient and tell them the test is positive, and what do? Of course, they freak out. They think they're going to die. They have cancer. Well, here's the thing. There's still only a 50-50 chance with this super awesome test that doesn't really exist in the real world with 99% sensitivity and 99% specificity. Even with that super awesome test, a positive result in a low prevalence population still means it's 50-50. Maybe you have it, maybe you don't. Okay? So it means that more testing needs to be done, and that's the problem with performing screening tests in low prevalence populations, because it leads to a lot more testing. It leads to, say in this case, maybe you have to biopsy some tissue. Well, that's uncomfortable and risky in some ways. Okay? To make a definitive diagnosis or to definitively rule out the diagnosis. Now again, if you apply the test again to a patient with 50% chance of cancer, the result is more meaningful with the next test. But the more the test worsens in reliability, say it's 90% sensitive and 90% specific, even that second test leaves you with a 50-50 chance of having the disease, okay? This is really relevant to the whole discussion about COVID-19 testing, right? In Jordan especially, the population prevalence is so low for COVID-19 that the testing isn't all that valuable because its sensitivity and specificity is way less than 99%, okay? Way less. So it's just something to think about, and that's even more true, say, with antibody testing. So the problem is when you test asymptomatic people and the prevalence of disease in those people is just, say there's 130 cases out of 10 million. If it's 150 out of 10 million, the prevalence is really, really low. So the testing is not very valuable in asymptomatic individuals. Now, it's very different if you have symptoms, right? Because that symptom has a likelihood ratio which increases or decreases the chance that you have COVID-19. And then on top of that, perhaps the testing then takes you the rest of the way to confidence in the diagnosis. But just know that an asymptomatic person in a low prevalence population who has a positive COVID-19 test, how likely is it they have COVID-19? It's not very likely. Okay, so you got to be careful in how we apply these strategies on a population basis or even to individual patients. So just to sum up, again, the main point of everything we've done, the first part was just to introduce you guys to the concept of Bayes' theorem. What is Bayesian reasoning? And it's just all about conditional probability, right? When events are conditional on other evidence that exists. The second part was to derive Bayes' theorem for you, hopefully help you understand the components of the formula from a few different angles, to introduce likelihood ratios and hopefully contribute to a better understanding of those and how they're used. And then lastly, we went through some concrete examples in the last lecture to help you understand Bayes' theorem and how to use it. So, final points. Last bit of summary to do. You will always deal with uncertainty. Okay, that's point number one. There's never going to be something that's 100% for sure in medicine. And never is strong. Never is very strong. But, there's always a tiny sliver of uncertainty, even in the most certain circumstances. So just get comfortable with it. Realize it exists and that you're always making decisions on the basis of probability, not on absolute 100% certainty. There are no perfect tests. Every test have performance characteristics, and those performance characteristics really matter when you apply them to real patients. So know all about the tests you're using in your field and their performance characteristics. Don't just do what senior doctors tell you to do. Think through the implications of the testing. What are its performance characteristics? Third point, testing will change the probability of a diagnosis, but perhaps it's much less than you think. Okay? So just remember that a positive test doesn't always mean the patient has the diagnosis. A negative test doesn't always mean the patient doesn't have the diagnosis. It depends on the prevalence of the disease in that population. It depends on the likelihood ratio of the test and such things as these, right? So, and as well as the test performance characteristics, its sensitivity and its specificity, its predictive value, in both in the positive and negative sense. And then lastly, please, do not worry about memorizing these formulas. I think after going through them, you're going to know them if you think carefully through them. But I'm not interested in quizzing you guys on the formulas. I'm interested in knowing you can use them to aid your decision making. So please do understand the concepts. Please don't memorize formulas. So to that end, I would ask you guys to get on Teams, ask your questions, get them answered. Maybe you can just ask them in the channel dedicated to this topic. If we need to, if there's enough demand for it, we can set up a time for us all to be online together where you can type in your questions and I can respond to them and answer them. Maybe we can do a Teams meeting for that. I'll check with Dr. Ben and see what he wants to do. But at a minimum, please do ask me your questions. I think you probably have some after all this. I want to make sure you get your questions answered. I want to make sure you understand this topic. I want to make sure you know how to use this information to help you as you seek to help patients who are, again, valuable because they're made in God's image by God. Therefore, we want to take really good care of them and do our best, even though we are not God. We are frail human beings. We don't know everything. We're doing the best we can with the information we have available. So that's what this course is all about. That's what this topic is all about. So please ask questions. Let me help you as much as I can. Thanks for paying attention. Thanks for thinking through these things. And I will talk to you guys later. Thanks.